But let's move on. Another trial that was presented in one form at AACR back in mid-April, and then further facets of this very complex trial, CheckMate-227, presented by Dr. Haas-Borgay at ASCO very recently. And it's really a challenging trial with a lot of questions being asked. Jared, can you just outline some of the key points, both of what at least we've seen so far and what it might mean?
Sure. So this was a very simple trial that gave us an absolute answer.
Right.
So this was a complex design. So patients were divided by their PD-L1 status in terms of how they were randomized. So those with a negative PD-L1 were randomized to Ipi-Nivo, Nivo chemo, or chemo alone, where those with a positive PD-L1 marker, any level of positivity, were randomized to Ipi-Nivo, Nivo alone, or chemo plus Nivo. And actually, I think that from a human perspective, that was a reasonable way to design this. The other novel thing about this trial was the use of biomarkers. In addition to PD-L1, this trial looked at and pre-specified in its statistical plan analysis by tumor mutational burden. So we've heard some about tumor mutational burden. It is just what it sounds like. You do next-generation sequences, next-generation sequencing, and it's a number of mutations per megabase. And we've seen in prior data sets in melanoma, in lung, in head and neck, I think basically every time we've looked, that this is a predictive biomarker. And I think it makes common sense. The more mutations you have, the more potential immunogenic neoantigens you're going to have, potentially the greater efficacy of these agents. And we've seen that before. So what we saw at AACR and in the New England Journal publication that followed.
This was by Matt Hellman.
Was that for patients with a high tumor mutation burden, we have to be careful how we define that because it changes every 20 minutes.
Yeah.
But in this study, for a tumor mutation burden of at least 10, we saw the efficacy of Ipi-Nivo compared to the other arms, both in PD-L1 low patients and PD-L1 high patients, and both in squamous and in non-squamous histology.
So that was the specific breakdown of what they focused on was Nivo-Ipi versus chemo doublet, although they did include a bit on Nivo as well, which kind of fell between the other two arms. But, and this was in terms of progression-free survival. There was a trend toward better overall survival, I believe, but not
early data, I think, on overall survival.
Right, fair enough. And then Dr. Borgay presented some additional data at ASCO, really just focusing on the low PD-L or the PD-L1 negatives, which showed that the Nivo chemo arm did better than chemo alone, but that this was also in progression-free survival, and that was limited only to the patients with high tumor mutation burden. You lost that difference in
right, so this may be worth summarizing by the statuses to be able to. So he showed us two key curves in that. He showed us a lot of curves, but the two key ones were in the tumor. All of the patients had PD-L1 negativity in what he showed us. For those with high tumor mutation burden, the top curve was Ipi-Nivo, followed by Nivo chemo, followed by chemo. With not huge numbers of patients at risk, actually, small patient numbers. But even smaller yet were the curves that he showed us for the double negative markers. So the patients negative for PD-L1 and for tumor mutation burden. I think it was 40 or 50-ish patients at the beginning of the curve. So essentially 3 phase 2 studies in terms of size. But what was interesting is those were absolutely overlapping curves. For the patients who were double biomarker negative, there seemed to be no benefit of integrating immunotherapy in any context. And given that while these agents may have lesser toxicity than cytotoxics, and I would say in my practice, I'm far less afraid of hurting people, at least with single-agent immunotherapy, compared to cytotoxics, they're not a free ride. If you're that person with one of the rare severe side effects, it can be awful. Mm-hmm. And so if that hypothesis generated by these small numbers ends up being true, those are people that we could spare these risks.
So one of the other provocative findings, though still limited numbers of patients kind of early, is the long duration of the responses seen, especially with the Nivo-Ipi combination, where it ends up with pretty small numbers. I think one of the challenges is in interpreting the CheckMate-227 is you started out with over 1,700 patients, and you're ending up with all these subsets that end up being a few dozen patients overall. But it looks like in patients who were responding well to Nivo-Ipi, they were very long duration, which is, of course, a goal that
extremely important.
we
This
really
is what our
want.
patients come in asking for. And so I don't think it's inappropriate, all of the attention that's been paid to the tail of the curve.
Right.
Our patients don't use those words, tail of the curve, but in more human language, that's what every patient comes in asking for. They're not asking us for an average expectation of an extra month. They'll take it, of course. But what they come in asking for is some chance at being alive 2 years down the road, 3 years down the road. And that's so from a human perspective, that's extremely provocative. I strongly agree with your commentary, though, on paying attention to the number of patients. When you get to that tail, it's extremely small numbers that you're talking about even being evaluated.
And we also will hope to see what this translates to in terms of overall survival with more time, because PFS alone is limited when we're talking about a campaign over what we hope is going to be several lines of therapy.